upper extremity, thumb, wrist, forearm, and elbow with Brandy Jones. Thumb, PA oblique projection. Here are two very nice images for proper positioning of the PA oblique thumb. Please take a look and review your anatomy. PA oblique thumb analysis practice number 1. What do you guys think? Take a look and see what you can review with this image. So the IP and MCP joints are closed and the phalanges are foreshortened, meaning the palm surface was not positioned flat against the IR and the thumb was tilting towards the IR. So for correction, the palmar surface and thumb should be flat against the IR. Thumb, lateral projection. Here are nice examples of proper positioning in anatomy. Lateral thumb analysis practice. See what you guys think. Okay, so the mid shafts of the proximal phalanx and the metacarpals demonstrate some degree of concavity on both sides, indicating that a PA oblique projection. So the hand was not flexed enough. So correction, flex the hand until the thumb rolls into a true lateral projection with the thumbnail in profile. And lastly, for the thumb, AP projection. Here are proper positioning and image of a good AP thumb. AP thumb analysis practice. What do you guys think of this image? Okay, analysis. The fifth metacarpal and the medial palm surface of the soft tissue are superimposed over the proximal first metacarpal and carpometacarpal joint. The metacarpals and the palmar surface have not been drawn away from the thumb. There is slightly more phalangeal concavity on the side of the thumb closest to the hand. The thumb was internally rotated slightly more than needed. So correction, using the patient's other hand, draw the medial side of the hand of the palmar surface away from the thumb. Make sure that the thumb does not rotate away from an AP projection with this movement, and that the patient's opposite hand is not included in the collimated field. We're starting with PA projection. These are proper positioning and image for wrist. Here is a PA wrist image analysis, practice number 1. What do you guys think? Analysis. The third metacarpal is not aligned with the long axis of the mid-forearm. The wrist was in radial deviation. The second through the third carpometacarpals joints are closed. The metacarpals are at a greater than 10 to 15 degree angle with the IR. So correction, the ulnar deviate the wrist until the third metacarpal is aligned with the long axis of the mid-forearm and decrease the second through the third metacarpal's angle with the IR. Wow, that sounds really confusing, doesn't it? So you just need to straighten the whole arm and wrist out in the same plane. PA image analysis practice number 2. What do you guys think? Analysis. The medial located carpals and proximal metacarpals are superimposed. The radial ulnar articulation is closed. The wrist was in external rotation for this projection. The posterior radial margin superimposes more than 1/4 of the lunate. The forearm was not parallel. So for correction, rotate the wrist internally until the PA projection and depress the proximal portion of the forearm until the forearm is parallel with the IR. Oblique wrist. So, is oblique wrist performed with an internal rotation or an external rotation? That's right, external. External is the only way we do wrists. If it were to be internal, all the carpals will be superimposed, all the anatomy gets superimposed over top each other, and nothing is really singled out here. So it is only a external. A oblique projection, external rotation. This is a example of proper patient positioning and a decent x-ray. PA oblique image analysis practice number 1. What do you guys think? The second metacarpal is superimposing the trapezoid. The second metacarpal was flexed more than 10 degrees with the anterior plane of the wrist. The posterior radial margin is superimposing more than 1/4 of the lunate. The proximal forearm was elevated. The trapezoid joint, wow, say that twice, space is closed. The wrist was rotated more than 45 degrees. So for correction, you're going to decrease the degree of the hand flexion until the second metacarpal is at a 10-degree angle with the anterior wrist plane. Depress the proximal forearm to bring it parallel with the IR and decrease the amount of external rotation. Lateral projection, lateromedially. Here is an example of proper positioning and a decent x-ray. Lateral wrist analysis practice number 1. What do you guys think? The first proximal metacarpal is superimposing over top the trapezium. The thumb was not depressed and placed parallel with the IR. So for correction, depress the thumb, placing it in the second metacarpal at the same horizontal level and parallel with the IR. Lateral wrist analysis practice number 2. What do you guys think? The anterior aspect of the pisiform is demonstrated anterior to the anterior aspect of the distal scaphoid. The wrist was externally rotated. So for correction, internally rotate the wrist until the wrist is in a lateral projection. Wrist. Ulnar deviation. A PA axial projection of the scaphoid. This is an example of proper positioning for the ulnar deviation view and the anatomy. PA scaphoid analysis practice number 1. What do you guys think? The scaphoid trapezium and the scaphoid trapezoidal joint spaces are closed. Forearm, AP projection. Here's a proper positioning of a forearm with accurate positioning. You want to center mid forearm. AP forearm analysis practice number 1. AP forearm analysis practice 1. Analysis. The laterally located first and second metacarpal bases and the carpal bones are superimposed. The medial located carpals are better demonstrated. The wrist was internally rotated. Less than 1/8 of the radial head is superimposed over the ulna. The elbow was externally rotated. The proximal and distal aspects of the forearm do not demonstrate even brightness. The proximal forearm was positioned at the anode end of the tube. Correction. Rotate the wrist and hand externally until they are in the AP projection. Rotate the elbow internally until the humeral epicondyles are parallel with the IR. Position the distal forearm and the anode end of the tube to take advantage of the anode heel effect. Forearm lateral projection, lateromedial. Here is an excellent example of lateral forearm, and you want to center mid forearm. Lateral forearm analysis practice number 1. Analysis. The elbow is accurately positioned. The distal radius is anterior to the ulna. The wrist was internally rotated. So for correction, externally rotate the wrist until it is lateral in a lateral projection. AP elbow projection. This is 2 good examples of an AP elbow. You want to center mid elbow. AP elbow analysis practice number 1. AP elbow analysis practice number 1 analysis. The humeral epicondyles are not in profile. Less than 1/8 of the radial head is superimposing the ulna. The elbow was laterally rotated. So for correction, rotate the elbow internally until the humeral epicondyles are parallel with the IR. AP elbow analysis practice number 2. AP elbow analysis practice number 2 analysis. The distal humerus is demonstrated without foreshortening, but the proximal forearm is severely distorted. The humerus was positioned parallel with the IR, and the distal forearm was elevated. For correction, fully extend the elbow if possible. If the patient is unable to extend the elbow, this is an acceptable projection of the distal humerus. A second AP projection of the elbow should be taken with the forearm positioned parallel to the IR. AP oblique projections, lateral rotation of the elbow. Here is excellent examples. And you want to center mid elbow still. AP lateral oblique elbow analysis practice number 1. AP lateral oblique elbow analysis number 1. Analysis. The capitulum radial joint space is closed. The radial articulating surface is demonstrated. The forearm was not positioned parallel with the IR. For correction, fully extend the elbow. If the patient is unable to fully extend the elbow and the proximal forearm is of interest, position the forearm parallel with the IR. AP lateral oblique elbow analysis practice number 2. What do you think? Lateral oblique elbow analysis practice number 2 analysis. The radial head and tuberosity are partially superimposed over the ulna. The elbow obliquity was less than 45 degrees. For correction, increase the degree of external obliquity until the humeral epicondyles are at a 45-degree angle with the IR. Elbow lateral projection, lateral medial. Here are 2 excellent examples of the lateral elbow in perfect positioning, accurate positioning. You want to center mid elbow. Lateral elbow analysis practice number 1. Lateral elbow analysis practice number 1. Analysis. The radial head is positioned too far posterior to the coronoid process, and the distal surface of the capitulum is demonstrated too far distally to the distal surface of the medial trochlea. The proximal humerus was elevated. Correction, depress the proximal humerus until the humeral epicondyles are superimposed. Lateral elbow analysis practice number 2. All right, analysis for number 2. The radial head is positioned anterior to the coronoid process, and the capitulum is too far proximal to the medial trochlea. The proximal humerus was depressed. So for the correction, elevate the proximal humerus until the humeral epicondyles are superimposed. Elbow, axiolateral projection, Coyle method. Here are two excellent examples of how the Coyle method is done and looks in the image. As you can see, it's just like the oblique. It allows the tuberosity and the head of the radius to be free of superimposition. The lateral elbow Coyle method, analysis practice number 1. Analysis for Coyle method practice number 1. The radial head is superimposed over more than just the tip of the coronoid process, and the medial trochlea and capitulum demonstrate slight superimposition, so the proximal humerus was elevated. The radial head is demonstrated proximal to the coronoid process, and the capitulum is demonstrated too far posterior to the medial trochlea. The distal forearm was elevated. The anterior and posterior surfaces of the radial head are demonstrated. The wrist was placed in a lateral projection. Correction. Depress the proximal humerus and the distal forearm until the humeral epicondyles are aligned perpendicular to the IR. Almost done. Here we have a first digit series, series of the thumb. We have an AP, an oblique view, and a lateral view. Right off the bat, it looks like we could have collimated a little bit better. We have a little bit more open top to bottom. We don't need that much radius and ulna. For the AP view, it looks like the hand is being closed shut almost. We need to open that up to remove all this soft tissue out of the first metacarpal right here. So maybe try to extend the hand out, maybe use the other side and try to pull the other 4 digits out of the way. The lateral or oblique here we're supposed to have open interphalangeal joints, but they look like they're closed off a little bit. So maybe the thumb is not all the way completely flat to the IR. And then the lateral, it's not terrible. We have the straight on the one side of the phalanx and it's curved on the other. You can kind of see the soft tissue here. Not the worst. Here we have a wrist series. So we have a PA, an oblique, and lateral view. I'm going to say we need a little more collimation. We should be collimating at the distal metacarpals here. Maybe a little more radius and ulna collimation here. We have an open space between the radius and ulna, so we know the PA is good with equal concavity on each side of the metacarpals. All the carpals are here, are oblique. It looks like the hand has been obliqued with 3, 4, and 5 slightly superimposing over each other like it's supposed to. But here, it's almost like the wrist is still PA. It still is partially open here between the radius and ulna. So we need to oblique the wrist forearm portion as well as the hand. The hand actually looks decent for the lateral. The radius and ulna are superimposed over top each other. You can see the lunate here. Metacarpals over top each other here, and no flying thumbs. The thumb is in good position here. Here is another wrist series. We have PA, oblique, and lateral. This PA, the centering is pretty good. We appear to have better collimation. However, it looks like we were not able we should not have curled the fingers up underneath of the metacarpals here. You only want to like curl them back a little bit. You don't want to curl them underneath of your other hand, your hand portion. The radius zone are open here, so that's good. The oblique, it looks like their hand is obliqued a little bit too much. And again, we have those fingers curling back. The lateral, the radius and ulna are almost superimposed. It looks like the wrist is turned. You can't quite see that lunate really nice. And it looks like the hand is also cupped here. So you need to straighten out the carpals here. And maybe that's all the patient could do. Maybe it was very limited. We're not sure. This is part of a 4-view wrist series. Here's the first two. Blew these up so you could see them better. Here is the PA view here. And then we have the scaphoid view here. So the PA, slight little bit in there, so it could be turned slightly. It looks like the hand is turned up a little bit, externally rotating slightly on this view. They have their fingers curling underneath. We are looking at the scaphoid. It seems to be pain around the scaphoid area, which is this bone here. So we have done a scaphoid view, which you angle and do an ulnar deviation for, and it appears there's a little fracture right there, which you really couldn't see all that well here. So this is a really nice, good example of why we would do that. Here is the additional 2 views of the four-part series. Here is the oblique wrist, and here is the lateral. Again, here you can see the slight little fracture on that scaphoid. Looks like the hand is obliqued a little bit too much. The wrist is not, the forearm portion is not bad. Here on the lateral, you can't really see the lunate that well. Radius and ulna looks like it's rotating forward. You need to rotate the wrist posteriorly a little bit. Superimpose these metacarpals a little bit better. This here is a forearm series, an AP and a lateral. And I thought this was a neat image to show you guys because one, you have some holes here, so some hardware was removed. As you can see here, here's a nice good calcification here on the AP of the radius, I'm sorry, ulna. And then you can see it right here on the lateral. So it looks like they have removed the hardware for some reason. So as much as you want to try after you have a fracture, you may not always get your anatomy perfect. However, you do want to try to get your epicondyles parallel here and straighten out the wrist, externally rotate the wrist slightly so you can get a better view if possible. Same thing with the lateral. It may not be 100% thanks to this fracture here, even though it's closed pretty nicely. Sometimes things just don't move the same they do anymore. The elbow looks really nice, and then it looks like we need to rotate our wrist a little bit, or it may not just go because everything else looks in a nice line. Here is an elbow series. We have an AP, and we have our radius ulna and humeral joint open, which is nice. It looks like we're leaning here. You can see the muscles coming out this way. So it looks like they're externally rotated slightly. The condyles, epicondyles should be a little bit better in profile here. Here is an oblique, and the humerus is looking a lot similar to the AP there. So you can tell it's rotated slightly. They have the radial head and the tuberosity here for you superimposition, which is what you would like. Lateral here, it's at a good 90, so you can see your fat pads. We have our 3 concentric arcs here. So this looks pretty nice. Looks like there's some slight, maybe the humerus is a little bit higher than the forearm because this is slightly closed off here. Here is an elbow series, a 3-view. We have our AP, we have that Coyle method here, and then your lateral. All right, so we have our AP, the humeral radial ulnar joint is open and nice. Looks like we're slightly turned out a little bit because our epicondyles are not quite in profile. That could have been a little bit better. Our Coyle method is actually pretty nice. You have the radial head and the radial tuberosity for your superimposition. We have our lateral with our 3 concentric arcs. Again, maybe on this image as well, the humerus might be a little bit higher because we don't have exactly a clear open joint here. Is an additional elbow series. I thought this was a neat case. It has a unusual radial head replacement here. So I just thought you guys would like take a look at that. AP, oblique, and lateral. And that's it, everybody.